Welcome to podcast number 14.
Wow, already. Hello, I'm Fran.
And I'm Minnie.
And as always, please do give us your feedback. We really appreciate it, and it helps us decide future topics. So this topic for podcast 14 is depression.
Yeah, so our podcast tip for today is depression is common in patients with chronic diseases. And when you have a patient with depression, consider asking 2 questions as a screening tool. The first question is to ask them, during the last month, have you often been bothered by feeling down, depressed or hopeless? And the second question is to ask, do you have little interest or pleasure in doing things?
Brilliant, thanks, Minnie. Yeah, so in fact, those for a time, those were questions that we were expected to ask of our diabetic patients every year to try and pick up patients with diabetes who may have depression, because it was felt that potentially we were missing quite a lot of them. So even if you're seeing patients who aren't telling you they're depressed, but they have chronic diseases or cancer, it's just worth asking those questions to make sure that those people are doing okay. Right, so we're going to start with a case. So Peter, age 30, comes to see you complaining of poor sleep and fatigue for the past 4 weeks. He describes feeling down with no interest in doing anything. And on further questioning, he mentions his fatigue. He has thoughts of worthlessness, that he's useless, lots of recurrent thoughts of death. Diminished ability to concentrate, and he feels very agitated, and his wife comments that he can't sit still at all. The lack of sleep is what we call insomnia medically, and he's also had a loss of appetite with some weight loss. So these are symptoms of depression, and I'll put a list up of the 9 symptoms, but people can also get the opposite to some of these. So some people actually gain weight, or in fact find that they're oversleeping. So just for you to have a look at those symptoms so you understand what they are.
Okay.
Going back to Peter, so these symptoms that are impacting on his relationship with his wife, and they're affecting his ability to go to work, and he's actually been missing some work over the past 2 weeks as he can't even motivate himself to get out of bed. He normally cares for his aged mother and has even stopped doing that.
Gosh, okay, that's quite a typical case maybe that you see in general practice, would you say, Fran?
Yes, although not that the man's caring for his aged mother, but yeah, you never know, do you?
No.
So actually we see an awful lot of depression, and it's... I think typically it's been underdiagnosed, and certainly in lots of cultures it's something that people are very reticent to talk about and quite often present with physical symptoms instead. But it's thought to be a very big problem worldwide, and contribute to an awful lot of morbidity worldwide.
It's certainly very active in our media at the moment, isn't it? All mental health issues and people trying to get rid of the stigma of saying that they're unhappy and that they're depressed.
Yes, and in fact our royal family have recently come out and talked about their mental health following the death of Princess Diana, which has been incredibly helpful. So how do we diagnose depression, Minnie? Okay,
so we use the Diagnostic and Statistical Manual of Mental Disorders, and it's now in its 5th edition. And in there we have the criteria. And depression is diagnosed if the patient has at least 5 out of the 9 symptoms that you've just described to us that Peter has, or the converse, that the opposite of what he's presented with, that you're going to put in a table, with at least one of these as a core symptom. A symptom is counted as significant if it's sufficiently severe or it persists and is causing significant distress or functional impairment. So it's having a big impact on their ability to function normally.
So in Peter's case, for example, he's not caring for his mum and he's unable to go into work. So that's obviously significant enough and having an impairment for him.
Yeah. Okay.
So, and moving on.
Yeah. So investigations. What would you do when Peter comes to see you, Fran? Would you do a whole load of investigations, or would you feel that this isn't really necessary with someone who's presented in the way that he has?
So if people presenting like him, I wouldn't tend to investigate. Occasionally, I may do someone's thyroid test if they were particularly sleepy and having weight gain and symptoms of an overactive thyroid. But like I mentioned, quite often people. Or an underactive, sorry, yes. But quite often people, like I said, in different cultures don't present with such a clear mental health picture, and they may present with what we call psychosomatic conditions. So obviously if people are presenting with physical symptoms, then you would need to be doing tests to rule out any physical symptoms, and also thinking, that if there was, say for example, there was a change in personality, then you may be wanting to think about brain tumours or cerebral causes. We talk a bit about the overlay with dementia, and certainly with dementia in the UK, we do screening bloods to rule out reversible causes such as thyroid or B12. Yeah. But typically, if Peter came to see me, I wouldn't be doing any blood tests at all. I would be diagnosing him clinically.
And then getting on with the assessment and treatment from
Exactly,
okay.
Yeah.
So there are other psychological differential diagnoses we need to think about, aren't there? So a grief reaction may present in a similar way, and it can be difficult to distinguish between the two, between normal grief and a depressive illness. But uncomplicated bereavement wouldn't generally have problems. People wouldn't generally present with problems of suicidal thoughts or psychotic symptoms, would they? So
and in fact There's a nice table that they did, Minnie, which again I'll attach, which sort of suggests the difference between them. And I think Minnie and I were discussing this earlier, where I have a patient who I'm caring for who is having a grief reaction, but in fact is very, very actively suicidal. And I think probably that there was maybe some depression there before, and then the grief has exacerbated that. So I am treating him as a depressive illness and actively monitoring him at the moment. But I do think it's important to normalise this. So I do see a lot of people after they've been bereaved who tell me that they're not coping and things, and very often I try and signpost them towards bereavement support, because it's very normal to grieve and for that to be absolutely overwhelming. But that's a normal reaction
from a depressive illness.
Exactly. Yeah, exactly. And then moving on, so I mentioned before that dementia may present as depression and vice versa. So people, if they get very depressed, they can get what's called psychomotor retardation, where they can completely slow down and almost sort of stop moving and stop speaking. And also depression has an impact on memory. So have a think about that. And certainly with a lot of my depressed patients, I would treat depression, a lot of my demented patients, I might treat them for depression or anxiety to see if that had any impact on their dementia symptoms. Yeah. Okay.
And the other thing to think about is substance and adverse drug effects, because they can also produce depressive symptoms. So if you're misusing alcohol or taking any other drugs like anabolic steroids or cannabis, cocaine, narcotics, and that again is associated with depressive symptoms.
Yes, and you need to ask, because people don't tell. You absolutely need to ask that. And then again, interestingly, so even prescription drugs can cause depression, and the classic one for me is beta blockers. People quite often say to me, I'm just so low taking my propranolol or atenolol. But other ones as well can also do that.
Being aware of the other medication that a patient's taking.
Yes, and then absolutely. And
finally, hypothyroidism, which you already mentioned, can present as depression. Often the symptoms are not that clear cut. Okay, so we'll move on to assessment now, Fran.
Yeah, so I think the most important thing that we need to be doing is assessing the risk of suicide in these patients with depression. So we've talked about their depressive symptoms, and how do we then go on to assess the risk of suicide? And I think the really important thing is to use that word. And I think there's a lot of hesitancy with clinicians to say suicide, and we're worried that maybe we're being suggestive or something, but actually all the evidence suggests is that we don't talk about it openly enough, and that when we do talk about it openly, that actually it's incredibly beneficial to patients. So you need to be asking, do you ever feel that life is hopeless and not worth living? Do you ever think about suicide? Very importantly, have they made any plans for ending their life? And I would also ask, if they have made plans, have they written notes to people? Because that can be, that gives you an indication of how serious they are. Do you have the means for doing this available to you? So, if they've been storing medicines, for example, and what's kept you from acting on these thoughts. So that's a really important thing. So we know that a good support network, so, a partner, children, supportive family and friends, that stops people from committing suicide. So, if they've got that around them and they would say, well, my family are protective, that lowers that risk. Mm-hmm. And then things like, interestingly, and I think this just doesn't go for mental health, but for anything, follow up on not really answers. So people quite often say, oh, no, not really. And I'm always like, well, what does that mean? Does that mean yes or does that mean no? Because it's a way
yes
of patients kind of... Yeah, it's like a politician, isn't it? It's dodging the question. Yeah. So we've talked about things that are protective in terms of suicide.
Risk factors,
But then conversely, things that increase the risk of suicide, we want to be mindful of.
Yeah, so if you're male, you're young or old, whether you are single and living alone or unemployed, those are risk factors that will increase your risk.
Yeah,
and also,
absolutely.
A history of a prior suicide attempt, or if someone in the family's committed suicide, or alcohol or substance abuse. And also, very importantly, Fran, is if they've been recently started on antidepressants.
Yes. So unfortunately, we know that risk goes up in the first few weeks of starting antidepressants. And in fact, I've had that happen with a patient of mine who actually, a colleague started on antidepressants and she became incredibly suicidal. In fact, she was quite complicated and was finally diagnosed with bipolar and had swung very quickly from one to another. But it was just luck that she actually didn't manage to kill herself. She'd driven to jump off a tower and they were doing building work at the entrance of the tower and she couldn't get past the builders. So it was only really luck that happened there.
Do you generally... Sorry. I was just going to ask if you specifically tell your patients that it can increase the risk of suicidal thoughts.
I think sometimes depending on the patient. So I think if they're talking about suicidal thoughts, then I would. And if they're saying I'm not having any, I may not. I don't think I necessarily would.
Yes,
I would tailor it to the person. Yeah, very much tailor it to the person. Sorry, I just wanted to go back to us talking about older people. So in fact, actually, my only other patient who's ever really properly tried to kill themselves, in fact, was an elderly woman who I asked outright if she had any suicidal thoughts, which she completely denied, but in fact had been hoarding medicines on the sly. And I think I don't know why in my head I kind of, when I was training to be a doctor, I never thought that old people would be that high risk group, but actually they are. They're very high risk, and I'm much more wary of them now when they come in saying they're low. So sorry, going back. So clinically, then you also things you'd be looking for is hopelessness, psychosis, agitation, and anxiety, and panic attacks. Although that's very woolly. A lot of my patients have a lot of anxiety and panic attacks. Concurrent physical illness. So sort of maybe an elderly person who's been diagnosed with a life-limiting illness. That might be someone to be wary of. And then of course severe depression.
Yeah. Okay.
Yeah.
So that's sort of how you're assessing the risk of suicide. There are obviously other things in the assessment that we need to do. So we'll move on from that to the other things. So we need to think about the wider family of the individual who's presented to you, and you need to think about if they've got any children, if there are any safeguarding concerns, if they are being cared for by the person who's presented to you unwell.
Yeah. So in Peter's case, he's caring for his mum and he's struggling to do that at the moment. Well, is she managing? Who's caring for her whilst he's feeling this low? So you do need to be mindful of those. And obviously, we don't know about the safeguarding procedures in Zambia, but you need to be taking action as per your local guidance. Yeah.
Okay.
And certainly, with children, so I think Minnie and I were discussing about how I don't necessarily sit and think in my head, oh, now I'll think about safeguarding. But I would be alerted if perhaps it's a single mum who's using a lot of alcohol, who's having a lot of suicidal thoughts, who's not taking her children to school. Well, then I need to be thinking about safeguarding, and I would need to be getting social services involved, and things like that. Yeah.
So those are sort of red flags, really, aren't they, to you?
Absolutely.
Think about that, Fran.
Yeah.
Okay.
Yeah.
And other things to think about when you're assessing an individual is other conditions that are running alongside their depression. So we've alluded to it quite a few times: alcohol or substance abuse. If they have anxiety or eating disorders, so there are other things that can be that might need treating as well as the depression. Whether they're having any psychotic symptoms, so hallucinations and delusions, that sort of thing. And we've mentioned dementia already. So So what we did previously use in the UK, again, so the powers that be sort of have these great ideas of extra things GPs can do, and then they decide that they don't want us to do them anymore. But one of the things very briefly we did was something called a PHQ, which is a depression questionnaire. And that was quite useful as a way of sort of, although time consuming, way of gauging someone's depression. And then you could treat their depression and then get them to fill it out again and see how things had improved. And that talked about sort of feelings of worthlessness and agitation and things. So I'll attach a copy of that, because you may find it, you may not necessarily want to ask the questions in the way that they're laid out, but it may be useful for you guys to have a read of. Okay. So I don't know whether the questionnaire asked them about social stress.
Social stress. No, it doesn't, Minnie. No, it's just much more about the symptoms of depression. So
these are quite significant, aren't they? As assessing someone's whether they've got other problems in their social life. So we're talking about sort of employment or financial concerns, poor living conditions, problems with interpersonal relationships, bereavement, which we touched on before. I think you'd struggle to find someone who doesn't have one of those things going on at any point in their lives, unfortunately. It's just a lot of it is how they're managing, how well they're managing it, isn't it? Exactly.
Other
parts of the assessment would be to find out if there's a family history or a personal history of depression. You need to find out about the areas of support that they have available to them in terms of friends, family, bereavement counsellors. If they're, certainly in this country, after a bereavement, there's the opportunity to have some bereavement counselling. And other support. So for families here, we have health visitors who will go and see families up to the age of about 5. The children are up to the age of about 5. And they can be very good at spotting and supporting, particularly parents, around depression, and help them manage.
Yes. Yeah, absolutely.
Just manage generally. I was trying to think of another word, but that's really what I'm getting at. Okay.
And then obviously we need to be asking about their past history of depression. And whether they've responded to treatment previously and what treatment they've had. So going back to Peter, Peter has a history of depression previously in his early 20s, which responded well to medicines. He is having some suicidal thoughts, but has no plans and feels he wouldn't act on his thoughts as he couldn't bear the impact on his wife and children. So they're protective for him. His boss is very supportive because his boss has had depression in the past, and so he's very supportive of Peter. Peter does drink the occasional beer, but doesn't take any recreational drugs or prescribed medicine. His only stress at home is his elderly mother, who he cares for, and she's getting frailer, and he's worried about her. And in fact, while he hasn't been managing her, his wife has been doing that on his behalf. His children go to school, and his wife looks after them, and they're both doing very well, and he has no financial concerns currently.
So he's in quite a safe environment, really, at home.
Yes. So in fact, his although he's young and he's male, his other risk factors for suicide are low. So we wouldn't be worrying too much about him at this point.
Fantastic. So we're moving on to management now.
Yeah.
So we've made the diagnosis, we've assessed various risks, and now we're going to treat or manage.
Yeah. So we talked about suicide risk, and we felt that Peter's was low, but if we felt it was high, we would either be referring them so I refer, if I'm very worried about someone, I will refer them immediately to psychiatric services to be seen the same or the next day. If I'm sort of moderate risk and I feel I can manage it, then I will follow them up more regularly in primary care. So it may be that, I see them within a couple of days to just see how they're doing. And I think what sometimes some of us forget is about what we say in the UK as doctor as treatment, is that actually sometimes a person, particularly with mental health, coming to a clinician and being listened to, that in itself is a treatment, and that in itself can make quite a big difference to someone. And in fact, I had someone yesterday coming in and seeing me, and she said that I just wanted to be listened to, and that's made me feel better.
Made a massive difference.
Yeah. So I think and I know lots of other people feel that we should be doing something more actively, but actually us just listening is something active. So sometimes we can just follow up those people and see, and if that suicide risk decreases or they're responding to medicines, then we lessen the follow-up. And conversely, if we're more worried, then we refer them. And I know there is a psychiatric hospital in Lusaka. I don't know how you guys access that in the immediate setting. But it may be that if they come in with a family member, then you can make sure that family member will keep them safe.
Okay. We've talked about other issues that people may have alongside, sort of comorbidities alongside the depression, such as the alcohol or drug misuse or an eating disorder. So you need to manage those issues, manage those problems as well as the depression. But that's obviously not for discussion now, but for maybe another time.
Another topic,
and also, if you're able to just sort of talk about other solutions, practical solutions to the stresses that's making their depression worse. So for Peter, he was really, he was worrying about his elderly mother. Well, there are discussions you can have to help alleviate that by having other people support him.
Absolutely. So maybe he has brothers and sisters that could help out a little bit more, or maybe, just give him a break for a week or two, simple things like that. Actually can make a huge difference.
Okay.
And so, sorry, Minnie. So if they have mild depression, how might we manage them?
So this is called a period of active monitoring. So rather than starting them on any medication, you just see them regularly, provide them information about depression, the course of it, and follow them up in a couple of weeks, to just keep an eye on them and make them aware that they've got this safety net, really.
Yeah, I think that's really true. And I think, people do have dips and they can just pick up on their own, and we don't necessarily need to medicalise everything. I encourage a lot of exercise in my patients, because we know, not necessarily, marathon running, but even just going for a short walk. Because we know it releases endorphins, which are these feel-good hormones. Also, sometimes getting, maybe not so much in Zambia, but in the UK, people are terribly housebound. They go to work in their cars, they sit in their offices in front of computers, and then they go home and watch TV. And actually just getting outside, particularly now it's summer, getting a bit of sunlight, that can just alleviate depressive symptoms. So I, instead of sort of saying go away and we'll see how you do, I kind of give them things that I want them to do, even just starting off with, just walk around the block, walk around the village, whatever it is, something very attainable that doesn't seem too overwhelming for them.
Excellent. But for those with more moderate or severe depression, obviously you're going to maybe give them that advice and offer them some medication.
Yes, absolutely. So, you're going to be considering an antidepressant and offering potentially some talking therapy. Now, I don't know in Zambia if you have that. Even in the UK, how much. How much talking therapy people can access is very difficult. It's very in vogue at the moment to do cognitive behavioural therapy, because it's I think because it's cheap, but don't tell the NHS that. But obviously you're going to be offering what you've got available to you. So if you don't have any talking therapy available, I wouldn't be offering it. But there are sort of more and more apps. So again, mindfulness is very in vogue at the moment. There's an app people can get on their phones called the Headspace app, which is free to begin with, and it's about sort of breathing exercises and calming your mind. So that's something that you could consider if people have smartphones, obviously. Yeah. So how do we choose an antidepressant, Minnie?
Well, there are various things to take into consideration. So one is if somebody comes to you and says, my mum's on fluoxetine, it's worked well for her, I fancy giving that a try.
Yeah,
so personal preference. But also you need to consider the adverse effects of the antidepressant. So if you're wanting to help someone with sleep, you might give them something that is a bit more sedating, or if you want to avoid that, obviously you avoid the drugs that either are a bit more sedating or that give you weight gain or have some adverse sexual adverse effects as well.
So all of them have the potential to give you sexual adverse effects, unfortunately. So in the UK, we use mirtazapine quite a bit. I haven't seen it on the formulary in Zambia, but that I use for people when insomnia is a really big problem, because it is very sedating. It works like an antihistamine does in sedating people, but again, it makes people gain weight. So it's very good for sort of thin people who can't sleep. But maybe if they're doing an important job or operating heavy machinery in the morning, then they don't want that hangover from the medicine. I didn't notice you had it on your formulary. You do have clomipramine, which we just don't use tricyclic antidepressants at all as antidepressants in the UK because they are so toxic in overdose. So we almost never. I would almost never use one. We use them a lot for managing chronic pain or migraines, but I would just stay clear of that, guys. And the other one, venlafaxine, apparently, but again, it's not on your formulary. If there's a risk of overdose, should be avoided because it's so toxic.
Okay.
Yeah.
So what does that leave us with then, Fran?
Well, so, I mean, typically we're all using SSRIs. You need to have a little think about whether they're on medicines which might interact with them. But my first go-to, and it's on your formulary, is fluoxetine. So if it's a new episode, think about prescribing that. It's very well tolerated. You can go up to 60 milligrams, which is good for sometimes for things like OCD and eating disorders. It's got a long half-life, which means if you miss a dose, you don't have terrible side effects, and it means it's very easy to come off after the treatment course. So that's what that's my first line go-to. Obviously, we talked about patient preference. And again, if people have had a previous episode of depression and they were on a drug that worked well for them, I'd be absolutely going straight to that. I also sometimes use sertraline, and that typically I use that in people who have other physical health problems. So we know with heart disease, sertraline is much safer. And also I use it in women who are thinking of getting pregnant in the near future, because it's of the drugs that we have. We know it has the lowest risk in pregnancy, although being on no antidepressant in pregnancy is the best. But that's the safest one. So I sometimes use that. And just to say, in older people, so all the SSRIs do have that risk of damaging your stomach lining, so the risk of bleeding. So if you're giving them alongside anti-inflammatory drugs or aspirin, you do need to think about using some sort of form of gastroprotection.
Okay.
Yeah.
And the treatment length, what do you generally advise then, Fran?
So I tell everyone that all of them take 3 weeks to work, and that they will just have side effects for the first 3 weeks, unfortunately. Sometimes if somebody's taken the medicine before, they notice it working sooner because they've got experience of it, that the side effects, that their anxiety may worse. We talked a little bit about how suicidal ideation can worsen as well. But once I've got somebody stable on the medicine, then they need to continue it for at least 6 months, and that reduces the risk of relapses. So it is quite a commitment.
Yeah.
But certainly, I'm happy to take people off at 6 months. Equally, if somebody is stable on it and doesn't want to come off at 6 months, I wouldn't force them to.
Okay, that's quite
but unfortunately, it does mean I have a lot. I think in the UK we have a lot of people who are on long-term antidepressants, which maybe isn't ideal.
So, what about our friend Peter? How's he getting on then?
Well, so poor Peter, he's used fluoxetine in the past with really good effect, so he's keen to try that again. In the past, he needed a dose of 40 milligrams to work, so we wouldn't go straight in at 40, but we might consider doing 20 for a week or two and then doubling up to 40 if the side effects aren't too bad. He doesn't want to talk to anyone about his mood because he feels that he's getting enough support through his wife and he can talk to her very, very openly. So we prescribe him some fluoxetine, and I wouldn't. So with my patients, I would only be giving them, depending on their suicide risk, maximum of 1 month's dosage
to take
and arrange for them to come. Absolutely, yeah. And if I was worried about the suicide risk, I might just be giving them like a week or even a couple of days, and that means that they have to come back in to see me, and then risk of overdose. Although with SSRIs the risk is much lower, you still don't want that risk.
No. Yeah. So that's quite a commitment for some patients to come back after a month. So it's important.
Well, interestingly, with us talking about this is the sort of NICE guidance. So NICE do guidance on all sorts of illnesses in the UK, and they say in terms of follow-up, with people with that you're worried about in terms of their suicide risk, or if they're under 30, you should be seeing them within 1 week when you've started them on an antidepressant, and 2 weeks for other people. And then you want to arrange subsequent reviews every 2 to 4 weeks for the first 3 months, and then consider longer reviews if their response has been good. That's a lot of appointments.
It is.
Yeah. That's a lot of appointments in the UK, and if I'm honest, I don't do that. I don't have capacity to do that. I don't think my patients have, they can't leave work enough to come and do that if they're working.
And if you've got a long way to travel to, certainly in Zambia, if your patients have got a long way to travel, that's certainly not really an achievable.
No, I don't think so. And I think it's important to remember that these are guidelines; they're not absolute rules. And I think in medicine we have to be very pragmatic, and we have to be treating the person in front of us. So for me, I know my patients very well. The way my general practice works is that I have a group of patients that are assigned to me, and that I see. They only come to see me, so I know them very well. So I maybe follow up by telephone in patients that I'm worried about, or quite often I'll say, right, I want you to do a self follow up in 3 weeks' time, and if you're better, we're carrying on, and if you're not better, you need to phone me and we'll make a plan. But they know that they can access me very easily if they phone up.
So that works. That must work quite well then for them.
So it works very well because I've got very good access. If they phone up, I will speak to them that day and sort out problems. But obviously in other places that may not work so well. So I think it's just, it's taking into account the person in front of you, their suicide risk, their previous history, what resources you've got available to you, and what's safe and what's pragmatic.
Yeah. So when you've reviewed Peter in 2 weeks, and then again at a month, because you've got lots of appointments available when you're seeing Peter, he's made a great improvement with his medication, and now he's back to managing to care for his mother. He's concentrating at work, and his wife's noted that he's much better, and he's interacting and playing with his children more, and he no longer has any suicidal thoughts. So he is doing really well and on the maintenance dose for 6 months at this point.
Yep, and then reviewing and seeing whether it's time to come off. Yeah,
fantastic.
Yeah.
Okay, well, thank you very much, Fran.
Thank you, Minnie. Thank you guys for listening, and goodbye.
Bye.